Welcome to today's webinar. The structure for this webinar is that we have a group of panelists and we have a speaker, and then we have attendees also. So I always say that attendees are also very important in terms of participation. When you have a question, there are two ways to participate. You can put it in question and answer, and also there's a chat group. Please introduce yourself in the chat group with your designation, full name, designation, where you are, and whatever you would like to share about yourself. So that should start now. And then what I will do is I will ask our speaker, Dr. Raza Khalid, who's an ID specialist, to introduce himself, to tell us about him, what is he doing, and then he can start the talk. And then I'll keep on collecting your questions, and in the order they are received, then I will, after the talk, I will introduce the, I will let panelists introduce themselves, and we'll start question and answer session. So please go ahead, Dr. Raza Khalid, please introduce yourself.
Assalamu alaikum. Good evening and good morning to Pakistan. My name is Dr. Muhammad Raza Khalid. I'm an infectious disease consultant here, as well as an ICU consultant at South Lake Hospital in Newmarket, Ontario, Canada. And as you all know, that we are seeing a lot of cases of COVID-19, so I thought I will have a chat with our colleagues in Pakistan. So I will start with my topic today that I will be talking about is infection control in COVID-19 situations. So there are a lot of things that we have to talk about in terms of COVID-19. Can everybody hear me? I'm not sure.
Gigi, everybody is hearing you. Go ahead.
So what happens is that before I go to the admitted patients, how do we deal with patients who are thinking that they have COVID-19, like they have the fever and cough? I will not talk about shortness of breath yet. So what happens is, if they present to the hospital or any healthcare facility, they should put on a mask. That's for sure. Number two, they should be at least 6 feet away from the other patients, and they should actually be cohorted. They should have a separate place. They cannot go to the place where others are staying. So once you admit them, the question is whether to have them in droplet contact precaution, or should we apply airborne precautions with N95 respirator immediately. So the data right now shows that we should do the contact and droplet precautions if they are mildly symptomatic and they do not need intubation. So once they get to a point where they do have to get, there's an aerosol generating procedure that we are anticipating, then they should be an airborne precaution with an N95 respirator before doing any procedure. Especially the aerosol generating. Now, there is a long list of things that people want to classify whether it's an aerosol generating procedure or not. The first thing is, what are the aerosol generating procedures? They are intubation, bronchoscopies, tracheostomies, upper endoscopies, upper endoscopies are aerosol generating procedures. So the other thing that I want to stress is nebulizers and high flow oxygen that we give to patients is also considered an aerosol generating procedure. So this is something that's very, very important. We do see, I think a lot of the places are giving high flow oxygen on the floors with just contact droplet precaution, which I feel is not, is not correct. So the other thing is, what do we do with the healthcare workers who are coming? The healthcare workers, now there's a recommendation of a lot of hospitals that they should have a mask all the time. I will talk about it later on. Why do they have to have a mask? There should be appropriate screening for patients who are coming to healthcare facility. If they can be managed as outpatient, they should be. So the other thing that a lot of hospitals have done is postponing all the elective procedures. That's another thing that a lot of hospitals have done. Now, the other thing is healthcare workers, how do they put on the personal protective gear and how do they take it off? This has to be practiced. Once you put it on, it has to start with the gown and you have to protect your mucous membranes as much as you can. That is the reason why we do hand hygiene before we go to the face and remove the face shield and the mask. So I think that's what I have. I want to concentrate on question and answers. I see there's somebody who said about CPAP and BiPAP. That's of course is an aerosol generating procedure. And actually, if a person, now the recommendation is that they should be intubated earlier than later. So I would stop here and I would wait for others' question and answers, and we'll take it from there. I'm open to answer questions.
So thank you, Raza. That was very helpful. And basically, that is what we like from our speakers, that it's just to initiate the conversation. Really, this program, this webinar is more for interaction and not just a speech or a lecture. So with that, I would like to introduce our panelist. Did I lose? Can you hear me? Yeah. I don't know what.
So there's a question here that how do you deal with immunocompromised hosts who need a procedure at this time? Number one, we are trying to minimize the number of studies that these people need. They have a very typical and set pattern of how they walk in and how they present. I have met a lot of my colleagues and we all have the same experience. By the time you see your third or fourth patient, you know how they're presenting. So they should have a mask all the time when they are being taken out of the room. This is like if they have to go for a CT scan, that cannot be done. Of course, it can be done in the room. So I suggest that they should have a mask all the time. There's another question, is there a recurrence chance of virus? I think we are getting a lot of, I just read the news from Korea that there were like 90 something patients who had a recurrence after they had. For now, we know that there are only 2 strains. It looks like one of the L strain is the predominant one. This is difficult to tell if this is really a recurrence or this is the natural progression of the disease. Because you have to understand that some of the complications of these patients develop later on. So
there is one question from Dr. Rashid Hanif. No, Rashid, you did not miss that. The question is that now that COVID-19 has so widespread community infection, should we consider every patient coming to the hospital with the symptoms as PUI?
Yes, now actually they are going to make this, this recommendation is on the way actually. And a lot of, especially a lot of places are actually pushing for it. There's a lot of utility to it actually. You can cohort them, you can contact tracing becomes more important. You can actually send them into a self-isolation earlier, and that can spread the disease. So epidemiologically, it makes sense to check a lot of people.
Okay, let me, Dr. Raza Khalid, go to our panelists and get their comment and any question one by one. And I would invite Asma Chima to introduce and then give some comment.
Assalamu alaikum, everyone. My name is Asma Chima, and I'm practicing internal medicine in Maryland. My question to Dr. Raza Khalid is, how many cases you have seen so far as a false negative? It's like clinically, we have suspicion that patient has some viral infection going on, and COVID test is negative. So we are doing now, we keep the patient on precautions, and we are doing tests twice to make sure, because it's a nasopharyngeal swab that we have to obtain. So how many cases you think is false negative, and is there any guidelines in Ontario, Canada that we need to do twice? Thank you.
This is a very interesting question, and actually Massachusetts General Hospital, they just released a report today. The positive predictive value of this test is very good. So if you have it, if it comes back positive, of course you have it. The negative predictive value is not that good, although it's a PCR test, and we all know that PCR tests are way more sensitive. They are saying that this also depends on the person who is doing it. If you don't go deep into the nasopharynx, there is a chance that it can turn out to be negative. And then there's another thing that they have noticed about this virus, that it does migrate from the nasopharynx to the oropharynx and then into the bronchioles and the alveoli. So they are saying that we might have to do a more invasive test like an oropharynx swab, or even like an induced sputum to see how to increase the yield. So this is what they're doing, and I agree with you that there should always, when the suspicion is high, you should always test them, because it has a lot of clinical implication for the healthcare workers, for the patient, their family, and while they're admitted. So what we do is we recheck them after 48 hours.
Okay, great. So next is Samreen Raz from Karachi Indus Hospital.
Assalamu alaikum. A very nice introduction and small lecture. The important thing that you have stressed is that it becomes airborne when we do certain aerosol generating procedures. My question is, when you say that it becomes aerosol generating, we have to keep a negative pressure, right? Practice airborne precautions and keep a negative pressure. In Pakistan, unfortunately, negative pressure is not present in many settings, like the emergency departments where patients are presenting with desaturation, and an IV is very much being practiced. In our hospital, the only thing that we could do was put in big exhausts and increase the air circulation, but it is not negative pressure per se. We are using N95s over there, but I'm a little concerned that is it enough? Especially when NIV is happening over there all the time.
Yes, actually, I totally agree with you. This is a very difficult situation to deal with. What we can do is put an N95 mask on the patient, put N95 mask on all the people, healthcare workers that are surrounding the patient, and that's all we can do. And I think you guys are already doing what you guys can do. I agree. This is a very difficult situation.
Do you have N95 in all your settings, or are you also dealing with compromised settings?
Well, if the person is very short of breath, and we feel that this patient would be needing and is coughing a lot, we do recommend that you put N95. But for other patients, we don't. For mildly symptomatic patients on the floor, we don't. A contact droplet is enough for them.
Okay, great. Dr. Morton, I'm going to unmute you. Please introduce yourself and your comment and question.
Assalamu alaikum. I'm Mariam Morton. I'm a staff cardiologist at Loma Linda University and at the VA hospital. I'm also at the UCR. My question was, we do come across immunocompromised patients, For example, patient has had a liver transplant and a kidney transplant, and they're already on a lot of immunosuppressive therapy, but they need some cardiac testing done, which are not without risk. And if there's anything else that you can suggest that we can do to protect those patients beyond the face mask. Thank you.
Yeah, this is a very interesting question. I accept that these people do need studies to be done. Are those, doctor, just a quick question. Dr. Mariam, can those be delayed or they can be delayed, those studies?
That's the problem. Oh,
Sorry, go ahead, Dr. Motin, sorry.
Sure, I'm sorry, I was not unmuted, but these are immunocompromised patients that are getting worse over time, and they need a valve replacement, and for that they need to have a TE done, or if they need to have a cardiac catheterization done, CT angiography to be done. The problem becomes taking these patients for those kind of procedures. We are always stuck in between rock and a hard place. Should we wait any longer? Because they're coming to a point that we can't wait any longer. So I was wondering if you have any other suggestion beyond the face mask for those people.
I haven't come across any more recommendation. Honestly, this is a very difficult situation. If you have to do it, you have to do it. But I mean, I would just go with the face mask. I don't think so. I have much to add in these cases.
Okay. Now I'll invite Dr. Noor Mahal Kabani to please introduce and give your comment and question.
Yes, this is Dr. Kabani. I was listening to the speaker right before me, and what I was going to ask was that are these patients that required procedures that are immunocompromised, do you in your facility have a dedicated place for the COVID patients versus the non-COVID patients, both on the floor as well as in the diagnostic section? Because that is what some of the hospitals are doing. They're keeping, like for example, if there's an ultrasound to be done, they're keeping one machine for the COVID patients. And so basically social distancing even in the hospital, in addition to the N95 masks, if that is a possibility.
You see, Dr. Kabani, it's very, very, we do have separate units for COVID patients, but unfortunately, we do not have separate machines of ultrasounds or echoes or something like this for the COVID patients. Unfortunately, there was a talk about doing it, but in the end, we decided against it.
I see, because I think that would be something, and even the probes could be separated, at least for the ultrasounds.
So thank you. I have a question, and I would see if Sayyida Noshin Zehra can ask herself. Noshin, I have unmuted yourself. Can you ask your question directly to our speaker?
Assalamualaikum. I'm from Karachi. I work as a basically in internal medicine. We are getting a lot of patients with typical symptoms of COVID, like bilateral basal pneumonias and young adults with no comorbids. But what is happening is that we have allocated one ICU for the COVID patients. And what happens is that these patients are being placed there, and when their COVID-19 PCR is coming negative, they are being stepping down into the regular ICUs and the isolation wards, where most of our staff does not have any PPEs. Many don't even have N95. And the ID is just making these decisions. So my question, and you know, we have seen about 10 such cases. So please comment on this.
This is a this is like playing with fire, actually. This can backfire a lot. I mean, do you plan to retest them just to be on the safe side? And have you retested some of them?
No retesting has been done. And that's really strange how so many patients are negative and they have typical findings, and none of them are, coming out of the vents as yet. And now they have shifted those patients to the normal ICUs. And in our setup, only the ID is at the moment making decisions. Only they can ask for tests. Not none of the other consultants can ask for retesting. So is there a guideline for any such thing so that we can, present that guideline to them?
Do you guys do bronchs there?
Yes, we do, but we have not done on any COVID patient.
Not on the COVID patient. Can you do induced sputum on them?
Yes, that's what we do.
Yeah.
We do induced sputum, and we do tracheal aspirations and such like procedures. Yes, we do.
So, this is it must be a testing problem that they don't have enough kits to do it. Because if they do have, they would have certainly retested them after a few days, and a deeper sample down from the lungs would certainly give you the answer. But if they can't do it, they can't do it. I mean, if they don't have, they're limited in resources, then they can't.
Yes, you're very right. We are very limited in resources, and yes, you're right. We cannot retest them because of mainly the resources problem.
And are the rooms single rooms, or are they shared? Like, is there enough partition between the patients in the ICU that's not COVID?
Actually, we were keeping the COVID patient in negative pressure rooms. We had some negative pressure room in our chest ICU. But once the PCR comes negative, they are sent to the normal ICU. The normal ICU have glass partitions. That's all. They don't have the negative pressure system on.
You see, the other thing that I want to point out is a lot of these patients who present with suspected atypical pneumonias actually could have some other viruses like influenza, and there are lots of other viruses that can give a lot of big problems in immunocompromised people and even in normal people like RSV. So we do check for them. So I don't know if you guys have access to that testing, that PCR.
Yes, we do. We have a respiratory panel which covers many viruses and bacteria. And yes, we do run that test on them too. Once it's negative, then, basically COVID is sent. This is the guideline we are following in our hospital.
Well, I think you guys have done the most that you can. And if it's negative, it's negative. And I still feel that it's a good test. PCR test is still good sensitivity, but some centers are reporting a 70% sensitivity, which I think is not good enough for a PCR test. So I don't know, there might be a problem in the testing. I mean, has it been done properly? I mean, if it's a typical case, then how can they miss it?
Dr. Nausheen, can I speak?
Yes, please.
Where do you practice? I practice at, yeah?
I'm practicing in Acute National Hospital, Karachi.
Okay. See, at Indus, when we are seeing typical findings on the chest X-ray and one negative PCR, we are always retesting it again after 24 to 48 hours. It's only after 2 negative tests that we basically break the we shift to the normal ward. And sometimes we are even repeating 3 samples. If we have a very high index of suspicion and we have like 1 or 2 samples negative, but still we get a tracheal or a deeper sample, and then we take another sample. So I don't think there's this kit issue. There are kits available. When you have a high index of suspicion, it's always better to get at least 2 samples rather than 1 sample before making such a drastic decision of shifting a patient out of isolation. And I think you should recommend your ID to do exactly the same thing. I know them and I'll talk to them.
Okay, that will be fine. Ma'am, may I know your name, please?
Dr. Samreen Sarfaraz.
Okay, okay, ma'am. I'll get in touch with you.
All right, thank you. I think I have to go to Dr. Rizwan Khalid is our president-elect. Rizwan, please, you're next. I think Noor Mahal, Dr. Kabani has something to add in it, and then I'll come back to you, Dr. Rizwan Khalid. So Dr. Kabani, go ahead if you wanted to add on this topic.
No, I just wanted to reinforce what Samreen said. That was exactly what I was wanting to say earlier, that you have to do at least 2 PCR tests before you, and especially in an atypical patient, in a typical presentation with a high pre-test probability, making a decision on 1 PCR test is not adequate. And I completely agree with Samreen from Indus who said that.
Okay, great. Thank you. So our panelist, Dr. Rizwan Khalid, is also the president-elect of APNA, and we are lucky that he joins us more times than than he can afford. I think with all his busyness with the central APNA, because he's doing a lot of work for the APNA COVID task force, and of course his own job with busy cardiology practice. So Dr. Rizwan Khalid, go ahead and introduce yourself and your comment. Rizwan, are you there? Okay, so I think we can get back to Rizwan later. And now the question that Dr. Mohammed Naeem, I think, let me see here, there is a hands up by I think Kaleem also. Let me introduce Kaleem, because he's a intensivist and dealing with a lot of COVID patients. Kaleem, do you have things to add?
Thank you, Shahid. I just want to get some data from Pakistan. Is anybody, I think we have somebody from the Indus and also from Liaqat. Looking at the numbers from what we're getting over Pakistan, how many COVID patient you actively have at Indus and also at Liaqat positive, and how many tests you have done, so we can understand the number of tests you're performing and number of certainly positive thing. As far as the data from the China and Italy we are getting, the sensitivity is ranging between 65 to 70% all over. So we want to see, is it something different in Pakistan or not? Yes, it is a very sensitive test, but the technique and the duration of the disease process, whether you're during too early, might not be able to get it. So if you guys please educate us about that. Thank you.
In this hospital, we have a very active screening process, and we have a case definition and a criteria on the basis of which we do testing. We have done quite a lot of testing, and what I will tell you is that I'm not allowed to share exact raw data, but around 12% of the samples that we send, around 12% of them come out positive. And then we have a policy of not admitting the mild cases or the asymptomatic ones or the mild cases. We send them off to a field hospital. If they can't maintain home isolation, we send them to Expo Center, which has been converted to a 1,000-bed field hospital. We only admit moderate and severe cases because we have basically made a dedicated COVID unit in which we have vents and air exchanges and obviously all the necessities of airborne precautions. We admit patients over there. And currently, and we are seeing quite a heavy burden of patients presenting to the emergency with desaturation and a typical picture who are coming out COVID positive. Currently, we have 9 patients on the bench at the Indus Hospital and 17 positive patients admitted with moderate to severe disease. There are quite a few that we have not admitted and sent to Expo Center at the field hospital or sent home.
Thank you.
Okay, so next I have other raised hands. So let me go to Pyari Lal Khwaja. Please introduce yourself and ask your question. Dr. Khwaja, are you there?
हेलो अस्सलाम वालेकुम
जी जी
आवाज़ आ रही है मेरी
जी जी बिल्कुल आ रही है आप
जी सर बहुत अच्छा लगा और बड़ी खुशी हुई कि आप लोगों ने हमारी नॉलेज में इजाफा किया अच्छा हमारे यहाँ मैं काफ़ी जो है लेक्चर सुनता रहता हूँ और लेकिन एक अमेरिका से हमारे एक रिश्तेदार है वो कह रही कि मुझे सिम्टम्स नहीं थे बुखार और खांसी नहीं था फिर भी जो है ना मुझे कोरोना वायरस का जो है टेस्ट पॉजिटिव आया तो ये मैं पूछना चाह रहा हूँ तो कि इसकी क्या है इसके बारे में आप क्या कहेंगे
जी रजा खालिद
जी काफी पेशेंट्स जो हैं वो होते हैं एक्चुअली एक सीरीज में तो क्लोज टू 60% पेशेंट्स वर एसिम्प्टोमेटिक उनको कोई सिम्टम्स नहीं थे और उनका कोरोना टेस्ट पॉजिटिव आया था ये चाइना से आई थी रिपोर्ट एक्चुअली ये बड़ा इंपॉर्टेंट होता है कि जो एसिम्प्टोमेटिक जिनको सिम्टम्स नहीं हैं उनको आइडेंटिफाई किया जाए क्योंकि ये लोग ज़्यादा उन लोगों को फैला सकते हैं जो कि एट रिस्क हो इसलिए ये नई रिकमेंडेशन जो आई है कि हर कोई जो है मास्क पहने स्पेशली हेल्थ केयर वर्कर्स तो हमारे हॉस्पिटल में पहन रहे हैं और इवन अमेरिका में रिकमेंडेशन की कि मास्क पहनी जाए वो इसी वजह से होती है कि उन लोगों के लिए जो कि एसिम्प्टोमेटिक हैं जिनको सिम्टम्स नहीं हैं और वो दूसरों को फैला सकते हैं तो ये काफ़ी ज़्यादा लोगों को जो है वो ये इस किस्म की उनकी सिचुएशन है
थैंक यू सर सर मैं हेलो
जी 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 बोलिए
माय नेम इज डॉक्टर प्यार अली ख्वाजा
अच्छा प्यार अली जी जी ठीक है
प्यार अली
थैंक यू सर okay next is Noshin you have another question go ahead Noshin Zahra Dr. Noshin Zahra
can I ask a question while you get to her?
Go ahead. Ji.
Yeah, there's a question from an eye doctor I know. They say they're seeing a lot of conjunctivitis and they're a little scared कि conjunctivitis अगर हम क्योंकि they're at risk. I mean they've not closed their OPDs, so they want to know what eye symptoms can specifically point towards COVID and how do they screen for such patients if they don't have any cough or anything, just redness of the eye and a patient is coming. So what should they do? Just wear a mask and examine them or what? Actually, what are the eye signs, eye symptoms and signs related to COVID?
I haven't come across anybody who says that they have a lot of eye symptoms. I know about loss of taste and lot of anosmia, but not eye symptoms. There's people with GI symptoms, but I haven't heard about eye symptoms, conjunctivitis being one of the presenting symptoms of corona. I think if you look at conjunctivitis as a separate syndrome, it is of course infectious because a lot of the viruses that give you conjunctivitis can spread by fomites, and there is person-to-person spread. So they have to have the same standard precautions that they follow.
Let me introduce Rizwan Khalid again. Rizwan, please introduce yourself I already introduced you here in the before, and go ahead and give your comment and question.
Yeah, sorry, I had to leave the screen for a couple of minutes. My kids were fighting, so I had to straighten them out. So my name is Rizwan Khalid. I'm the president-elect of APNA. I'm a associate professor of cardiology by profession in interventional cardiology and director of cardiac electrophysiology here at the border of Kansas and Missouri. So I just wanted to thank Dr. Raza Khalid, who happens to be my older brother as well, for an excellent talk and an excellent participation by our colleagues from both the US and in Pakistan. So I don't have a particular question, so I would just continue to hear if there is any particular question related to cardiology. I'll be happy to answer. We have written a review article and has been submitted for publication in one of the European journal on infection control and epidemiology, and that is particularly on cardiac manifestations of COVID-19. So I'll be happy to answer any particular cardiac questions that you may have. Again, thank you very much.
Okay, great. Dr. Raza Khalid, there's a question, two questions that are pending. I think I'll tell you both. One is that recently there is update from USA that a new oral drug, EIDD2801, is underway. Have you heard about it, or any of the panelists?
You know what? There's a lot of stuff going on all over the world. There are tons and tons of medications, okay, that are just being tried. I think we should just not sidetrack. Let's stick to the stuff that the amount of knowledge, the amount of research that's being done on this, even in my hospital and my other, it's so much that it's hard to keep up with them. I suggest that we stick to the ones that are more proven than the other one. Actually, there's no RCT trial for any of them, so who knows? That might work. So let me answer a few questions that are coming here.
Go ahead,
Dr. Rafiq. What is the normal waiting time for nasal swabs for its results? Why should we not take 2 swabs at a time to wait for normal and delayed results? This is by Dr. Muhammad Naeem. Actually, one kit for us here in Canada costs us about $131. That's a lot of money if you look at the patients that we are seeing. So I think it is logistically going to be difficult to do two swabs upfront. The other question that I have is, should the same stethoscope used for all patients and same stethoscope we wear in neck touch on body and clothes, and how to prevent? This is a very important question. We do have dedicated stethoscope for these people who are suspected of being COVID positive, and using your stethoscope is another fomite transmission might take place. So this is something that we have to be very, very careful. It does linger on the surfaces from anywhere from 2 to 4 days. So that has to be kept in mind. And then there's another question about the chloroquine tablet, the side effects of chloroquine, is hemolysis, hypoglycemia, please explain. Well, the chloroquine is we are using more hydroxychloroquine, which is Plaquenil. It does have side effects, and we have to keep them in mind, especially when you're using it with azithromycin. We use the corrected QTC. But we have to note that it's being used for a very short time for these people. Usually you're not worried about the retinal problems and the QTC if it's used for just 4 or 5 days. So that's something that I wanted to just answer. The other question is the BCG vaccination. It's hard to tell right now. All these theories are coming in. It's very early to say that if BCG makes a difference. Okay, Dr. Rafiq, back to you.
Thank you. I see the raised hand, and I'm seeing Dr. Khadija Munir. Please go ahead and
We can't hear anything. Can we move to the next question?
Hello? Hello?
Yeah, yeah. Go ahead, Dr.
Can you
Maria.
hear me now?
Yes, we can hear you.
Okay, Assalamu alaikum. I wanted to know that what is your experience regarding HCQ in treatment of moderate to severe symptoms? Is it really helping your patients in clearing the virus early? Because what we are facing in Pakistan, that we are running short of these medicines and it's not available at the pharmacies, and then at government level they have told us that we will be providing it, but it is not being given to our COVID positive individuals with symptoms. So I would like to know, is it really helping and should we pursue this more at our setup or just wait for the research results before prescribing these medicines? Thank you.
You're talking about Plaquenil, hydroxychloroquine?
No, yes, I'm talking about hydroxychloroquine.
You see, I have seen patients who are already on hydroxychloroquine for other diseases,
Yes.
and they got COVID-19.
Yes. We are facing the same. Even many patients who have rheumatological problems, and then they are already on HCQ, but they are presenting with similar complaints. But we think that they might be immunosuppressed because they're on other medicines as well at the same time.
Right now, the only medication that is showing a little bit of promise, I don't know, there's no RCT trial. Nobody knows by way that this works or not, is Plaquenil. So, this is what we have. I mean, I know lot of hospitals, it's on back order and they can't get it. But if a person is in the ICU, I would suggest to give it. If he's not in the ICU and doesn't have shortness of breath, then there's no need to give it. Some people are even recommending it as a prophylaxis, which I think is a big injustice and should not be done, because this should be reserved for later.
Okay, thank you.
All right, so let me go to Pyarali. You have another question? You go ahead, please.
Ji sir, I talked about chloroquine. So Dr. Saab already explained it.
Okay,
Yeah,
great.
I have answered that question.
Okay, great. So any of our panelists?
Can I ask a question?
Okay.
Yeah, Shahid, can I ask a question? This is
sure. Go ahead.
So one of the things I was going to ask came to my mind is that we are seeing a lot of these microvascular dysfunction with significant, almost like a DIC picture, where thrombosis is happening at the same time as hemolysis. And there are centers, Montefiore is giving Eliquis from the get-go. Their heparin has been given. We are checking a D-dimer as a baseline, and if the D-dimer is over a particular number, they are just being started on Lovenox or heparin or Eliquis. What do you do in that regard? Somebody asked me about TPA. I have not used TPA, but I would at this point in time probably not use TPA, because especially in DIC and in TTP, TPA is contraindicated. So what are your thoughts about microvascular dysfunction due to thrombosis and hemolysis?
Actually, they are recommending prophylactic heparin dose. It's not the full dose. In spite of all these microvascular thrombosis, I think somebody else has also pointed about this Sayed Noshin Zehra, how much of pulmonary thrombosis you guys are seeing. So it's the prophylactic heparin. It's not the full dose heparin that we are giving. I would like to know the opinion of the panelist. Who else is using it?
We are also using prophylactic heparin or Clexane, but we are not using any therapeutic anticoagulation at the moment. although we are seeing quite a high number of people with D dimers, very high.
Dr. Kabani, you had.
Yes. What I wanted to say was that we are using full dose anticoagulation prophylaxis for everyone. Lovenox versus heparin. Heparin has some anti-inflammatory properties as well. The full dose anticoagulation is used in a situation where if you have if you're in the thrombotic phase, in the late phase of the disease, in a very severely ill patient, severe hypoxemia. I saw 3 patients on my last shift that were in the prone position, severe hypoxemia, could not get them to ECMO. There was really nothing else we could do for the patient except to anticoagulate on the presumed diagnosis of possibly thromboembolic disease. And so we are using, this particular patient that I saw was on a low dose molecular heparin, but from what I read in the literature, was on Lovenox or low dose, low molecular weight heparin, but IV heparin is also being recommended because of the anti-inflammatory. So there is a role for it, and if you don't have any other options, anticoagulation is certainly something, because we know that it causes thromboembolic disease.
All
And
right.
there is some literature on it. I'll find the reference and send it.
Yeah.
Somebody has already shared something, it looks like, on the screen.
Algorithm, is that from Raza? Or?
It's from, I think Dr. Moten just shared something.
Okay. Dr. Moten, you had any comment on this topic? I unmuted you, Dr. Moten.
Yes, all that I want you to know that the protocol is varying from institution to institution, and this is what I got from Mount Sinai only this afternoon, so I thought it was worthwhile, sharing it with everybody.
Okay, yeah, that's great. Now let me see. There is one question from I think it's the Dr. Pyar Ali Khaja again.
No, sir.
Okay, so then let
answer.
me get your hand down, lower hand. Okay, so now I'm fine. All right, so back to I have one question with Dr. Raza Khalid, is there a reason why these patients, I have not directly taken care of them, but learning from different colleagues, why do they decompensate so much, and why do they fluctuate so much? Sometimes they get worse, then they get better, and then they get worse again very quickly.
That's the natural history of a viral pneumonia. Viral pneumonias are very necrotizing, aggressive pneumonias. And why the pneumonias that you see secondary to viruses are usually complications. They are not the disease. Their primary infection is upper airway infections, and then they progress down to the lower airways, and they progress very quickly, a high cytokine response, and they require a lot of PEEP because there is a lot of inflammation at the micro level. So they are collapsing and opening, collapsing and opening. Some people are not agreeing with this concept. They think that this is not an ARDS and there's something else going on, which I completely agree. But what happens is that these patients are very PEEP dependent. They need a little bit of PEEP, we call it, to positive pressure to keep the airways opening for their oxygenation. And if they do anything like they exert themselves or do anything that the airways collapse, they really desaturate. So it's until the body heals, they are at risk for hypoxemia.
Thank you. Go ahead.
Yeah, may I intervene? I think the gentleman was really referring to the two different phenotypes that have been described, the L and the H phenotype, and of the lungs. The L phenotype is the one where everything is low, the compliance is low, the resistance of the lung is low, and there is just fluid in the lungs. The H phenotype is when the compliance is, sorry, the other way around. The L phenotype is the one that has the decreased compliance of the lung, and the H phenotype that has a high compliance of the lung. So when the compliance is good, and believe it or not, these patients vary from day to day within with the phenotypes. And this is created by the disease process itself, as was said earlier, depending on the inflammatory markers that are being generated. And so what we are doing is that we are putting the patient on and we'll talk more about it in the ventilator course, that we are putting the patient on pressure control ventilation, and then measuring their lung compliance on every 2-hourly basis and from day to day. And we have to change our ventilator strategy accordingly. So the ones that are where the compliance is normal, they can tolerate a high PEEP, they can tolerate a high tidal volume, whereas when the compliance is not good, then those are the ones that require the real ARDS pathology. And this is all coming from the Gattinoni paper from Italy. And I'll put the reference and the slide related to that on our forum, so that can be shared with everybody.
Okay, great. One thing that some of my colleagues here are doing, the doctors, and they told me to do, but I was thinking of getting it, that they are saying that you should daily drink vitamin C and zinc. How much is the evidence for that, or is just anecdotal, or anybody else is doing that prophylactically for healthcare workers?
I think vitamin C has shown to have some effect against the viruses that roam around during the winter months. You're talking about zinc. Zinc, this is a very interesting thing. The latest study that is being done in Boston is about azithromycin, hydroxychloroquine, and the addition of zinc. So who knows, there might be some, I'm really looking forward to that study. So who knows, that it might have some effect, but right now it's all hearsay.
Okay, great. So Kaleem, I would invite you to say something. You have question or comment?
Well, talking about the fluctuation of the patient and deterioration in those patients who was very sick in critical care unit, there were some publication from our experience with the MERS, and in those patients, they extrapolate that in COVID patient, these are the same kind of phenomena is happening. Like there was about 18% superimposed bacterial infection has seen in MERS population, and they are extrapolating that we should be paying attention to that as well here. And depending upon what kind of pathological data you have related to the microbiological data you have about your own institution, one should cover those antibacterial. So I would like our ID expert to shed some light about this issue, whether this deterioration is not only happening just because the cytokine response and inflammatory process, but also they may be coming under the influence of superimposed bacterial infection.
Actually, Dr. Kaleem, this is a very interesting question. When we saw, if you look at influenza, when it gives you a viral pneumonia, there's a high chance of secondary bacterial infection. We all know that. We all see that a lot. But for some reason, COVID-19 patients are not getting a lot of bacterial pneumonias on top. They are very far in few cases of reporting. There is, I know, Pseudomonas is one of them, Acinetobacter is one of them that has been reported in some studies. But if for some reason it's not as common as influenza. And actually the patient who have high cytokines, actually they do worse. They have this prolonged fever for a very, very long time. This is what we are seeing. So that is why, that is where the immunotherapy is being used. What is your experience about it?
Well, here we are treating the same way. Like if we are experiencing the patient is not improving and they're further deteriorating and oxygenation is not improving, then we add broad spectrum antimicrobial, either with MRSA coverage or Pseudomonas coverage, at least for 4 or 5 days to see what kind of response we're going to get.
Actually, Dr. Khalid, it's very interesting. There are lots of patients in these who can have a prolonged fever for up to 14 days or 18 days, I'm seeing, in a lot of the, some of the COVID-19 patients, especially younger people.
Yeah. Mm-hmm.
Okay, thank you. I have a question from our attendee, Zahid Hussain. Please go ahead, Zahid. Zahid, you have to unmute yourself as well. I'm unmuting you. Yes. Who's this? Oh, this is PR. All right. Who is, there's another, please introduce yourself. I unmuted you. There was another hand up. XT1254. I see talking permitted for all these. All right, we can come back to them. So any of the panelists, we are coming close to, I think we are getting over to our time, but any last comments by our panelists? Dr. Moten, you have any last final round of comments?
That's an excellent explanation. I just wonder if you know how long does it take for the lymphopenia to recover?
A week, 5 to 7 days.
Okay, I muted, there was a background noise. Okay, so next, Dr. Kabani, any last comments, a question?
Oh, sorry about that. I was looking for the reference. I'm going to post it for you to share with them for the comment I had made earlier. The only thing that I would say is that you know, there was some discussion about repeat testing, which is very important. But I would not use induced sputum for anything because that is a definite risk factor for spread. So I hope that that is not being done anywhere, to induce sputum to get. Now, if the patient is intubated and you have a closed circuit with an inline suction, that would be the way to go. But I would not do a bronchoscopy or induce sputum to obtain specimens to retest.
Okay.
Totally agree.
Right. All right. So then, Samreen, any last comment, question?
Yes, I just wanted to ask a question from Dr. Rizwan Khalid. We are seeing a lot of viral myocarditis where the EF just drops to 25% and there are very high drops. Do these people recover? He's written a review article, so I wanted to know, or are they left with cardiomyopathy? I mean, do they recover completely, or is there a subset? And how much percentage are left with permanent damage?
So, excellent question. Obviously, we do not have enough experience to say how long-term these patients do, whether they recover completely or not. However, I can tell you with the data that's out there, patients that have any evidence of cardiac injury, whether you measure it by BNP or you measure it by troponin, they do much worse. Even if these are the patients that will get intubated more, these are the patients that will have prolonged intubation, these are the patients that will have a higher mortality. So cardiac injury by itself is a poor prognostic marker. And that, yes, in myocarditis, that is what is seen is just like a typical picture of fulminant viral myocarditis. On one day, their EF is normal, and then in a couple of days, you will see that the EF drops to 10% or 15%. These are the patients, their lungs are not doing well, their heart is not doing well. There is not much you can do. You provide hemodynamic support. That's pretty much it. So I think the experience, at least what we have seen, is not that long to say that how many of them improve significantly, but it's a low number. Patients with acute myocarditis that have acute respiratory failure do not do well.
Yeah, I absolutely agree. All of our 7 mortalities have had myocarditis along with respiratory failure, and we couldn't do much to help them. And all those who are recovering are the ones where there is not much high troponin or BNP. So I agree.
Okay.
I have a comment. I would like to make this. Somebody made this comment about using full dose heparin for microvascular thrombosis.
Yeah, I think Dr. Kabani.
Yes, I
Yeah. You see, I don't know, is this the standard of practice now to use? Because there was this recent paper which said that they had a lot of bad outcomes. People bled a lot because they were not sure which way they were going. So I don't know how many people in COVID-19, they get pulmonary embolism. I haven't seen any. Dr.
Well,
Kabani, I would like to know what
actually, we have seen, and the way that we have diagnosed it is usually the inflammatory markers are very high, the troponin levels are very high. If you're able to do an echo and you can see severe right ventricular dysfunction without significant left ventricular dysfunction, that is when we are using the heparin in these patients. If possible, we can do an ultrasound, but we are trying not to expose more and more technicians to doing an ultrasound of the lower extremities. These are the patients that also have a difference in their lung compliance, the H and the L phenotype that I was talking about, because they have more thrombotic. Their hypoxemia is more from thrombosis rather than from the typical ARDS picture. So there is some data for that, and I will go ahead and send you where can I send the references, Dr. Shahid?
You can send it to apnamerit.com.
Okay.
And in our WhatsApp group that you're part of.
Okay. That's where I've been posting. I just wanted to make sure it got
and
to.
we are getting Waleed is getting them onto our web page, apnamerit.com, the first web page, and we are creating a special web page for all the references.
Yeah, this morning I attended a seminar from Canada actually on thrombosis and COVID, and there's a very good references in there as well. And it's a good resource to look at the role of anticoagulation there. So I will definitely post it.
All right, thank you. So the last one, I think XT1254, again, one more chance. I unmuted you. Can you speak?
हेलो अस्सलाम वालेकुम
जी जी
मैं डॉक्टर हफीज़ बात कर रहा हूँ
डॉक्टर हफीज कहाँ से बात कर रहे हैं आप? इंट्रोड्यूस करें।
कराची से, मैं चाइल्ड स्पेशलिस्ट हूँ। मैं एक हदीस शेयर करना चाहता हूँ। असल में ना एक
जी।
हदीस है कि 3 बीमारियों को आप मकरूह मत जाने, जिसमें ज़ुकाम भी है। ज़ुकाम के बारे में ये है कि वो कई बीमारियों की जड़ें काट देता है, ये हदीस में है। तो ये है, मैं ये सोच रहा था कि क्या हम इस पे रिसर्च कर सकते हैं कि ज़ुकाम किस तरह बहुत सारी बीमारियों की जड़ें काट देता है। जैसे BCG के बारे में डिस्कशन हो रहा है, तो ज़ुकाम की वैक्सीन या अनएटेनुएटेड वायरस और ज़ुकाम कैन दे हेल्प in some way to this the treatment of coronavirus। ज़ुकाम की हदीस है ये, मलफूज़ात आला हज़रत के पेज 22 पे है। ये पूरी हदीस है पूरी, कि ज़ुकाम कई बीमारियों की जड़ें काट देता है। तो इस डायरेक्शन में अगर रिसर्च हो, शायद कोई ट्रीटमेंट निकल जाए कोरोना वायरस का। यही बोलना चाहूँगा, ये हदीस का हवाला देना।
Dr. Raza Khalid, any or any of the panelists after Raza Khalid?
Actually, this is something that's when they made this phage therapy, there was something that was done in Russia. What they did was that they put in some viruses that were attacking the staph pneumonias, very bad staph pneumonias. Actually, that was one of the therapies that they used initially for MRSA treatment, and of course the MSSA pneumonias. They basically, they gave a boost to the immune system by putting in viruses that could, actually that's what BCG does in bladder cancer, is that it basically gets the immune cells to a place where there's cancer to get it activated. So there might be a role, who knows? I think time will tell.
Dr. Moten, you have...
I have a couple of comments. One was to answer the question for Dr. Samreen Sarfraz regarding patients' recognition or reevaluation of left ventricular and right ventricular function. I had a couple of patients that came in after the infection was over. I have not seen the ejection fraction improve as of yet, but the functional capacity has markedly improved. Like they could barely talk, and now they're able to walk about a block or two without getting short of breath. So they are having functional improvement at this time. But as far as the ejection fraction is concerned, whether the left-sided or right-sided, I've not seen a difference as of yet, but it's been only 1 month. So you never know, it may recover over time. The other comment was about the thrombosis, systemic microthrombosis. If the COVID patients are not improving or they're worsening clinically with increased requirement for oxygenation and they have elevated D-dimer, then at that time we do consider full dose empiric anticoagulation, because at that time, you have really used all the resources that you needed to use to help those patients. Thank you.
Thank you. I think we are now closing the session. I would invite Dr. Rizwan Khalid, one of our panelists, to please close and thank all the attendees.
Again, Ji, a very spirited conversation and participation. I'm very glad that I'm very happy that we are having excellent participation from Pakistan. I certainly would like to see a lot of other institutions participate. I know there are some from Indus Hospital that always join us, Dr. Sarfraz and Dr. Harikar. So again, we want to thank you for joining in. We hope we are able to contribute in a little way. We all learn from each other, and we all are learning about this particular disease that we've never dealt with before. I want to thank the speaker for it's way past midnight in his time zone, for giving us the time and answering all the questions, and all the panelists that have joined, and obviously the chair of the merit committee. Thank you very much.
Thank you all. Assalamu alaikum.
Like I said.
Assalamu alaikum.
Islam.